CataractCoach.com podcast series episode number 58 with Dr. Lisa Arbisser, Excellence in Cataract Surgery. Welcome back to our Cataract Coach podcast. And today I have a very special guest, Dr. Lisa Brothers Arbisser, a fantastic ophthalmologist who's been such an educator for decades. I even recall back more than 20 years ago, being at an academy or ASRS meeting in a wet lab and having Dr. Lisa say, no, let me teach you how to do that, and literally holding my hands. So fondness in my heart for you, and I'm so appreciative of all the teaching you've done. Welcome to our podcast.
It's really a privilege to be here. You have become an icon in making teaching accessible to our entire profession, and it's really quite something. So I count it very special that you remember anything that I helped with.
Oh, you were so instrumental. In fact, that's one of the things that kind of propels me, is to pass on like how you taught me for me to teach the next generation. And so I think, now in the digital era, we can just get our message across worldwide instantly.
It's quite amazing. And, it used to be for me, I used to maybe do some coaching individually. I sometimes do. I'll go into the OR with somebody, just to observe and, make notes in my mind. And then we can go over videos later. And, it's one-on-one. Whereas, anybody who has an issue, a problem, a question, you can go online and find some very legitimate and wonderful, helpful answers from you. So it's quite something you've achieved.
Oh, thank you. We're still learning so much. I remember last year, I was very honored to give the Wolf Foundation lecture at University of Iowa, and I showed a case of a phaco wound burn. And then afterwards, you had some extra pearls for me about how to handle that, things that I didn't even realize. So even now, 25 years into my career, I'm still learning every day.
Well, that's really the beauty of ophthalmology, isn't it? And the fact that we need to do that. I actually gave that Wolf lecture a few years before you, yes. and the thing is that I think that the key to not only enjoying your professional life, but also serving patients, is to be constantly aware of being an early adopter. For me, there was a very fine line between, I've never been on the leading edge. I sort of consider that the bleeding edge, so it's having the wisdom, to know when not to miss the bandwagon nor eat its dust, not to jump on it or eat its dust, because, different things require different understanding of that, of what it might mean. Like when topical anesthesia was described, I did it the next week. If it can be done, I can do it. When a clear corneal incision was described, I waited 6 to 8 months to do that. I waited a long time for foldable lenses, because until clear corneal incision, it didn't matter that much. It was a couple millimeters difference in your scleral tunnel, So I missed a lot of problems with that. Anyhow, those are the kinds of things that we gain with age and judgment and knowledge and wide reading of the literature, as well as meetings and learning new things.
How do you find that balance of like you said, you could be an early adopter at the leading edge, which may be the bleeding edge, or you could be a real late adopter where you're in everyone's dust. How do you figure out that balance of when to get in?
Well, I think part of it is the problems that you're presented with by patients, so I, one of the wonderful things that happened to me was going to the University of Iowa for my training, which at that time was a 3.5-year residency, kind of a mini fellowship, and really being trained in a way that I could go out into practice. And my husband and I started a practice, and I did open globes, I did buckles, I did PKPs and trabeculectomies and plastics even, and really I learned phaco pretty much on my own and didn't go full time into it until the capsulorhexis was described. So part of it is a background of a holistic knowledge of how to assess various, I think it's kind of a shame that we concentrate on anterior segment versus posterior segment. And in fact, I'm one of the advocates of maybe having a middle segment subspecialty, which I think, is becoming more and more germane to patient care. And living in Iowa, was a big decision for me growing up in Manhattan, after training in Iowa, to decide to live there and practice and raise a family. And my husband had grown up in the Midwest, but not there. But, my dad said, he was a physician on Park Avenue, and, the only live culture is going to be in the yogurt, it wasn't the least bit true. And it was just a joke on his part anyway, but we went where we were needed. That was really the point, and so what I could do is I could learn things, I could read about it, I could learn it. If it was evident, it was required and not easy to find by my patients, then I would go and shadow somebody who did that a bunch. And then I would say to patients, I have the knowledge and I believe the skills to bring to the table to fix your problem, but there is somebody who does that all the time. And I'll be happy to send you to that person for this problem. And I'll still take care of you when you come home and be in touch. And, you'll still be my patient, or I will take care of it for you if you would like to trust me to do my very best. And that was an ethical way of doing new things. I was in the IDE for CTRs, and really never, part of my not being on the leading edge was that it was a private practice, and we really didn't have a coordinator, research coordinator, and all of that. And there were certain things I was willing to do and others I wasn't. Like, when I know placebo isn't as good as treatment, am I going to compare something new to placebo? Well, for me, no. It's a matter of thinking through, of having a holistic knowledge, and then thinking through and looking at people's results and reading the literature and deciding what takes time to prove itself as safe.
Right.
And then jumping on as soon as you feel it's there and it's needed.
Yeah, it's a delicate balance. But yeah, you brought a lot of firsts to your area. You said about the CTR, the capsule retention rings, but you brought many other firsts to the area.
Actually, when we first moved to Iowa, I was the first to do outpatient cataract surgery. The first, all sorts of things. First to do sutureless and all kinds of things. Actually, using off-label devices. I even went to our local university, to the ethics department. And ended up being on the citizens advisory board of that, but to ask, how do I properly inform patients of something that's new and not yet FDA approved, but I think has significant benefits. And, they advised me about how to explain that to people. And we even videoed a lot of that, just so we would have that sort of thing, and then let people make a fair and informed decision for themselves to some extent. Many patients can't do that, but many can and deserve to.
Well, and by being such a great patient advocate, you grew this tiny one-room practice to 4 locations in 2 states with 24 doctors and 200 employees. Tell me about this whole process. That sounds amazing.
Well, to start with, I have to give my husband credit. My husband's a pediatric ophthalmologist. We've been married for 48 years now. We met at Princeton. I was second class of women to matriculate there. My 50th anniversary is this May. And he was a senior. I was a freshman, and we met, and our parents met and loved it. It's almost an arranged marriage in a way. It took us 6 years to decide to marry. And he just has a great business mind. And he also has an amazingly appropriately adjusted ego. So as soon as he felt that I was doing a better job of cataract surgery than he was, he quit doing it like that. Or as soon as he felt that the practice needed, that our area could not support 2 pediatric ophthalmologists, and other practices were talking about competing with us in that way, he recruited a great person by just giving him all his surgery. Wow. Right off the bat. I think the other thing is we're a little socialist about it. It was really his concept to divide up. Well, first of all, it took us 10 years to get a real partner because we were mom and pop, and one person wouldn't feel they'd be fair necessarily, treated fairly or whatever. And so it did take us time. But I think the main thing in building this practice was just doing a great job and caring about patients and caring about caring about our employees like family. And we also have 4 children, so we also cared about our home care people, just like family, paid them the same way we paid our office people, who were far more educated. But that way we had the same people for 30 years at home, with our kids. It also, he pushed me a lot to do certain things. For example, I enjoyed seeing patients for their routine 1-year visits and all that, for a period of time. But then I was really great at surgery, and I couldn't do more. So he had me transition from that to only seeing surgical patients, from that to I developed a course with when I was president of the of ACEs, American College of Eye Surgeons, on the perioperative care of the cataract patient with an optometrist of ours, in order to be able to co-manage within our practice. So anyone who saw a post-op of mine had the same information, the same, what is a LOX3, what is a 3+ cell, that sort of thing. So always cognizant of best patient care, we added subspecialists, and then of course I stopped doing, retina stuff. And if we divided our money in a certain way that was very fair, I could be 4 days a week, and when my kids were little, and nobody would be upset, because part of the compensation was how many days you work, not just production. Or and we also wrote off the bottom line of the practice Medicaid and insurance things, so people wouldn't cherry pick their patients for payment. So there were a lot of things that led to that. I think when we started, part of it might be that we were fairly renowned because my mother was world famous as a psychologist. I don't know if you know Dr. Joyce Brother. She was considered the mother of media psychology. And so everywhere I went all my life, it was sort of, look who's coming, look who's here. But then we rapidly changed it from being about her to being about us, to a great extent through philanthropy, as well as just doing a great job and being someone that people could trust for a good outcome.
But I should also mention some unusual philanthropy, like bringing the circus to town. You have to tell our audience this. This is amazing.
We did not bring it to town. Every year, Barnum and Bailey, by the way, when I was a child, I even got to ride one of the elephants in the parade, and I always loved the circus, so nobody really knew, but it was my 50th birthday present from Amir. But really, it was to celebrate 20 years of doing surgery in the Quad Cities. And my husband, Amir, totally on his own, had the brilliant idea, to let's do something for the patient, something really special. And, the greatest show on earth, when I make you see, you want to see color, you want to see movement, you want to see fabulous stuff. So he actually was the only individual in the history of Barnum and Bailey to buy an 8,700 seat one performance of the circus in our area, and they made me honorary ringmaster. We sent 2 tickets to every patient I had ever operated on, so they could invite somebody. And we had all the public school teachers come, and our of course our employees' families, and we gave everybody a free popcorn. It was a year of planning. 30,000 pieces of mail. The sky boxes were donated by the community so people in wheelchairs could come. And we had medics, and we had tents, and we had buses. It was wild. And it was amazing. We got letters for years after that. I would never have been with my father on the day that he died the next day. And I'm sure he lived just to be at the circus, and I was with him, and thank you. And I remember 90-year-olds that remembered holding their dad's hands to watch the elephants put up the tent, but they could never afford to go to the performance. And just amazing things. Agoraphobes who felt after this they could go out again, and just it was an incredible impact that was just so heartwarming and beautiful for all involved. And it was really my husband's brainchild.
Wow, what an incredible idea for your secret 50th birthday. I love it. That's fantastic. And obviously, patients are so appreciative.
We have thousands of letters. Actually, we have a friend of one of my children that does some very creative things, and he may do something. We saved the letters. We just couldn't throw them out. I mean, there were just 1,000 letters or more, thousands of letters that, were so amazing stories and heartwarming things. And maybe we'll make something out of that somehow. I don't know if that'll happen, but anyhow, that was extraordinary. But we did many little things too, and anything we gave to, we put the practice's name on as well as ours. And the only thing we ever advertised, we didn't spend money on advertising. It was word of mouth. The only thing we had to advertise was LASIK early on. If you didn't advertise the LASIK, the phones were quiet. And, I had a partner that did that. I never did LASIK, or I chose not to do RK. And by the time LASIK came around, I already had a cornea specialist partner.
Oh, fantastic. Now, I think you have some very important ideas of how to grow that practice. And one of them was, and this is probably a big challenge for a lot of ophthalmologists in the community, is you were super fair. Because oftentimes it's the more established doctor hires the new one and kind of takes advantage of him or her, especially financially. It happened to me. That's why I left that situation and just did solo practice. But it happens to, I'd say the majority of my colleagues that I know or friends in ophthalmology, it's happened to them.
Well, we had 2 years of, being an employee to be sure that we could get along.
Right.
And then the guarantee was to become a full partner at that point. And we did a lot to make that happen early on. It took us 10 years, as I said, to get somebody to join us. And there were 2 wonderful subspecialists coming out of the Army who were friends together, who joined us together. And they really couldn't afford, to pay what the practice was on paper worth, so we traded call for that, and we paid for call, and we, so that they were able to come in at a lesser price, and they were, willing and able to, to take the call, and we would be responsive to our own patients, but not all the hospitals, and so on. They did that. And so there were many ways in which, part of it is our plan from the very beginning was to be in practice for 30 years. We thought that would be enough, and then we should have another life, and that's pretty much what we stuck to. The last 4 years, we job shared. Another unique thing that my husband's brainchild was his brainchild as well.
Tell us about that. That's with the Arnolds.
That's right. Priscilla was president of ASCRS, and I knew her through ACEs and various things. And Paul was a resident with me at University of Iowa. And for personal reasons, they had changed their own situation and were together and later in life, and were not that happy with their situation. And so my husband came up with this idea that, we're near the end of our practice. We want to take up more time. We want to be with, the kids, and they're very places, and so he came up with the concept that they would just come for a month, plug into everything we have, use all of our overhead, our trained assistants, be in our ORs with our techs and everything, and we would leave, and then we would work for a month, and they would leave. And we did that for 4 years. And, we were a great team, and it's not like we had to leave so that, if you had a complication or something, you could stay, but that never did happen, and we were able as a team to do a great job, even pediatric trauma and so on, we would explain to them, I would be the surgeon, Priscilla would be there after, she was there before, and we're a team. And we did some great patient care that way, and used our overhead more than anybody else, because we only had maybe a couple of days of overlapping, meetings to go to, and otherwise we were there full time using our overhead. And we took the risk. Our partners were not going to even consider, so we took all the financial risk for that, and it ended up wonderful, and everybody was satisfied.
Yeah, such a novel idea. I've never even thought of that.
Well, and a month was all I felt I could really take off and sit down for my first case and feel comfortable, and we had faith in their abilities. So, nobody would be harmed. And if I'm the name and people want to wait an extra couple months for me, big deal, they'll wait. And if they want surgery now, Paul and Priscilla had a great book of surgery right from the start.
That's so fantastic. And then you've transitioned the practice now to your other partners, and you're now fully retired.
Oh yeah, I'm fully retired from patient care,
Right.
almost fully retired from ophthalmology. Well, I transitioned into the joy of more teaching, really. But yeah, we didn't put our name on it. It's Eye Surgeons Associates. We specifically did not put our name on it because we wanted it to be all theirs when we were gone, and not be responsible for what they do or vice versa, and so that was part of the beauty of having people join as full partners, is that we were 2 of 12 partners by the end, and a good part of the reason that we were also comfortable to quit when we did, because they had other ways of looking at things than we did, and their goals and so on were a little different than ours, so it worked out that everybody got control when they needed and deserved it.
Yeah, it's such a wonderful way of doing things. Makes so much sense. Now, you also have some side projects, like the Minute Clinic, the Minute Suites. You got to tell us about this.
Well, I had an idea years ago when I was traveling to meetings and everything, and I was just so miserable in airports. There was no place quiet from all the announcements and all of this. Wouldn't it be great, if you had a little hotel room or a little thing? And we'd traveled the world, and you have those things in other places, and there was no such thing in the U.S. So my husband took the idea, kind of my idea, but he ran with it and implemented it. And we're in, I think, 13 different airports right now, and it's a room to rent inside security. That's the key.
Yeah.
Is that you already know exactly how far you are from your gate. There's no uncertainty of lines and this and that and TSA. And we have a surgery center cleaning protocol, so it's the safest, cleanest place you can be. And TV, a computer, a day bed. You can noise canceling and light and temperature control, and rent by the hour or overnight. And some have bathrooms and showers to rent, not all of them. So you can just lock your door and go out to the public restroom if you need to, or leave your bags there. There's nowhere to. I think this really came to a head when when they stopped having lockers for your bags because of bombers and things, and so you'd have to drag your stuff with you or whatever, so you couldn't exercise in the
Right.
airport or go nicely to eat. So you can leave your bags and so on. So that's been sort of he's CEO of that, and we have a number of mainly Quad Cities investors, our friends, and it's been a long haul, and we're hoping this is really going to maybe pay off at some point soon, but we'll see about that. It's a great idea. Once you've stayed there, you don't want to be anywhere else if you have a layover.
Yeah, I think it's brilliant.
Yeah, thanks. Yeah. So he's really an entrepreneur, as well as a
Right.
wonderful pediatric ophthalmologist, and never had any real interest in academia at all. He didn't. My projects revolve more around trying to improve cataract surgery and ophthalmology, and those are things that I've not had a whole lot of traction in getting people to change to. But for years, I went to Vienna to train with Rupert Menapace to learn primary posterior capsulorhexis and optic capture, since he had done a marvelous prospective intra-patient inter-eye study on this that was, to prove it non-inferior. And I did that for all my pediatric cases, anyone who couldn't sit for a YAG, and sometimes as a premium thing to do. And I couldn't really get anybody to bite to my way of thinking. If you're going to have an intact hyaloid for life, never have secondary visual loss from posterior capsule, and you always prefer the eye with no capsule compared to that 20/20 perfect Snellen acuity capsule because it's stray light, why wouldn't you add 2 minutes to your case, with 150 learning curve, and learn to do that? On the more forward-thinking side, I'm interested in capturing. Unfortunately, we have so little technology on 3-piece lenses, but for years, for really bad zonules, I was involved with that for a long time. As I said, I was on the IDE for the CTR, and soon learned that CTR isn't good enough to keep people from having bad lens subluxation.
Sure.
For whatever reason, I'm only aware of one in all the maybe 30,000 cases I did, only 4 subluxations and 1 dead bag that I'm aware of to this date, but I don't have all my data the way I really should. But for a long time at the end, I would place a 3-piece lens in the sulcus, optic capture anteriorly with a CTR in the bag, and they were way more stable. I did that very early on. They were very stable compared to a lens in the bag. So, but they all needed a YAG fairly early. So later, after I stopped seeing patients, it occurred to me, and I had done this in some trauma cases and so on, that why not capture from the sulcus through anterior and posterior capsules, kind of like the bag and the lens. Marie-José has taught me so much and is so brilliant about the retrolenticular space that is still a huge fertile area for understanding and progress in ophthalmology. And I'm still looking for somebody interested in doing a non-inferiority study on that, with the long-term hope, if we do it in pseudoexfoliation patients, that we may have less bag lens subluxation. But of course, that we can't document for 8 to 12 years, but you can see the stability and the lack of pseudophacodenesis and the lack of phimosis and all of that, so tried to get ESCRS to do it this past year. I was encouraged to show them the study. We wrote it at Utah, where I'm adjunct professor, but they couldn't find a principal investigator. Nobody's interested in going there right now.
So interesting. So what I would do now, if I had a pseudoexfoliation patient and I'm operating and the bag is very loose, when you have your empty capsular bag, I would do what you said earlier. I'd put a CTR in the capsular bag. I'd put a 3-piece lens, haptics in the sulcus, and then capture the optic behind my capsular X. And I have found also that even on the table, if I have the IOL in the bag, there is a shaking or shimmering or moving. But once you do that optic capture with the haptic in the sulcus, it's totally stable.
And it blocks the phimosis of the anterior capsule because the optic is there. So you don't have to do early relaxing incisions. And the only trouble with that is you're going to YAG all those patients pretty much, and that means you're blowing their hyaloid. And often they're a little early, so you also don't have the stocking in, so you lose your 2-chambered eye really, because you don't really have that barrier that you would have in a late YAG, and so I feel strongly that keeping that hyaloid intact for life is going to have benefits for glaucoma as well as retinal detachment. Menapatchy only studied out to 6 months, in a coordinated way. So he did a non-inferiority study, but it stands to reason. Also, when you opt to capture, you don't have to worry about the size and, centration of your lens, when you, changing in a big eye and, so on and so forth. So I think there are a myriad potential advantages. So maybe try my hyaloid sparing double capture when you have bad zonules, and that patient will see without a YAG forever. Right. And see what happens, because there's no one has done that in any numbers so far, to my knowledge.
Take us through the steps. So you have a patient, you do, again, pseudoexfoliation patient, very loose zonule support. You get the cataract out. Now you have an empty capsular bag. Now what's your next step?
Your next step is you put your OVD, cohesive OVD, in the sulcus so that you make a single plane of your anterior and posterior capsules. Okay. Then you take a 30 gauge and you're sure that all your, everything, there should be no posterior pressure. It's amazing how little there is. If you look at intraoperative OCT, which Marie-José has done, Tessillon in Belgium, you'll see that the anterior hyaloid is just so diaphanous, right? But when you start your rexus, you could have a potential space of the hyaloid right in contact with the posterior capsule, or it could be a real space, often a real space, because fluid has gone behind zonules. And if you're, like some people that jack their pressure up, and I think the best thing that's happened lately is physiologic pressures in machines, in phaco machines. I digress. At any rate, because of that potential space, you need to take a 30 gauge. You want to go high gauge. You want to have a nice view. I always put Viscoat in the beginning of a case on my cornea, a few drops of BSS, and then no one ever has to irrigate that eye again. So the patient isn't flinching, and you don't have to depend on your, tech to know when to fix your vision or have that moment of not seeing, when they're irrigating. And so you go on high mag, you've got your 2 capsules together, you take a 30 gauge syringe, a 30 gauge needle, and you make a wrinkle in that posterior capsule so that you then can lift a little circular tag off of that. Okay. Then you take your cohesive OVD and you put it down through that hole you just made, and that'll cause the hyaloid to go backwards. Okay. And if Wigger's ligament's intact, you'll see it fill completely into itself. But in old people, often Wigger's isn't intact. So at least you do see it start to fill, but you won't be able to get a full burger space, fill. But you just need to know that your hyaloid is enough away from your posterior capsule that starts to have a hole. Now, I would only do a primary posterior rhexis if I know I have a decent anterior rhexis, because that's my safety net, right? Because I can always capture, forward capture, back, anterior capture, whatever. And so you have that as a cookie cutter. And so now you just take the edge. You can use a regular, a lot of people like to use a small, Utrati, the small one that goes through a paracentesis, but you have such beautiful control of the chamber virtually always. When you start this, you can just use a Utrata, and your forces need to be a little more centripetal. It's a little more like a pediatric cataract. It's more elastic. It's about 4 microns thick instead of 14 like we're used to with the anterior capsule. And so you just grasp and you re-grasp more often, because you always need to be pulling in a little, or else it expands like a pediatric cataract, like a pediatric capsule does. And so you're pulling in just a little bit until you complete it. And now if you want to standard optic capture, now you put your OVD into the bag to separate your spare tire, right? You have your anterior rhexis above, your posterior rhexis below, your hyaloid well controlled below that with OVD cushion. And now you put your 3-piece lens. Don't use, another half a millimeter or millimeter of incision is fine. Do not do scleral, scleral assist, tunnel assist, because it'll shoot in. You want nice control, and you want to just lead that anterior, the anterior haptic, the leading haptic, straight into the bag, and then you can nicely rotate it into the bag. And any OVD left behind doesn't matter. It doesn't have access to the trabecular meshwork. It will not create a pressure rise. Menapace showed this conclusively in his studies. And so now if you have a lens in the bag, or you've put a 3-piece in the sulcus and bicapsulotomy captured, then you don't have to worry about what's behind the lens at all. But whatever's behind the lens, you keep. But now that you've done your posterior capture only, now you need to, it's nice to put a little Myocol E, or else at least hold the capsule back. You can't afford to lose chamber anymore, because you might uncapture, just like as if you had a vitreous loss. You need to be careful that you remove the OVD from anterior to the lens, and don't allow an uncapture. And you have a beautiful routine case with no possible. In children, unfortunately, we don't have a 90-degree optic haptic junction lens. And also, it's a pity that we don't have toricity on it, because anytime you capture, you're never going to rotate, right? But LAL, I'm thinking, might be good for this kind of thing, because it is 3-piece, though it's not at all a 90-degree optic haptic junction, because the only place that cells can sneak is at the optic haptic junction. And so if that's very broad, like in a 1-piece lens, it's not ideal, although Jason Jones has captured a lot of those, but I think it allows the potential for vitreous prolapse around, or cells to grow under. And in children, the cells are so aggressive, they can grow on the anterior hyaloid. But still, it's rare that they do, or it takes it 5 years and one little touch with the YAG once they're old enough to sit, So I did that in all my pediatric cases, and as I said, in people who don't sit for YAG. So that's how it is. It adds 2 minutes to the case. Menapace says it's 150 learning curve. I had one complication in my first 100, which was a pediatric intumescent cataract that probably had dysgenesis. Marie-José has shown us there's dysgenesis of Berger space in the anterior hyaloid and capsular attachment in posterior congenital cataracts very often. So you may not be able to achieve that real space in those, and have to do an anterior vitrectomy, which of course is the standard of care presently, for pediatrics.
Now, what about the case where you're going to put a CTR also, the bad pseudoexfoliation? Are you putting that before doing the posterior capsular rhexis?
Good question. You can do it before or after. Menapachi says you could do it even if you start and it's hard to do to make it go because it's so loose. But I never was bold enough to do that personally. So if it's loose, if that bag is loose, put your CTR after you've done, and you don't want to ruin zonules. So there are nuances about your anterior rexus as well. Supporting it and properly treating your anterior rexus so you don't destroy zonules. But the point would be to place your CTR before you put the OVD and the sulcus, right? To collapse the two membranes together. As soon as you've finished your phaco and you're polishing, if you want to polish, you really don't have to. But I think it's really good to polish your anterior and really be clean about this when you're doing posterior optic capture. Because when we do it and you're not doing a primary posterior capsular rexus, it increases the YAG rate to really aggressively polish your anterior capsules because you don't get that sandwich effect. But when you're doing this, that doesn't matter. And the other advantage in pediatrics of posterior optic capture is now you'd be able to open your bag and put in a secondary lens, in the sulcus and anterior capture for if you need a secondary lens after the eye grows, if we don't have perfect lens or some other way of adjusting our outcome, our refractive outcome for children.
Are you adjusting the eye wall power then? Let's say you have an adult cataract with loose line support and you're going to do a primary posterior capsular rexus, capture the 3-piece lens optic behind the posterior capsule. Are you now adding a little to the eye wall power, adding a half step?
So there's no perfect nomogram. Menapachi didn't get around to it. He was going to do it, and for some reason it didn't happen. But basically, you add 50, you add half diopter to it, unless you're way high. If you're way low on your power, it doesn't really matter. Keep in mind that the posterior capsule is so flexible, that it's not going to be dramatic. I think if you had, an over 25 diopter lens, you might consider adding 3/4 of a diopter, but no one has done a perfect nomogram for that as yet. But guess what? Menapachi did show that the effective lens position remains stable when you posterior optic capture. Don't have to guess. That's the main variable that we don't have control over.
Effective lens position, for sure. That's the big variable in IOL calcs. Yeah. So it's so interesting here. It's a neat concept, something I really haven't thought of. Hasn't gained widespread traction here in the U.S.
Not at all. Well, for one thing, you don't get paid much for it. You're in a hurry. There's a little chance of a little extra risk, when you're learning, especially. And I did get to speak at the AAO one year at the Controversies Symposium, and I spoke for it, and Osher spoke against it. And the only thing he spoke against was that there might be more complications, until people really learn. But I just can't get anybody to, you make so much money on YAG laser capsulotomies, that there's just no incentive to prevent them. But, particularly with us doing, but people are just timid. You've spent your entire life being told, don't touch that posterior capsule, and it's just not rocket science. If you can do a reliable and good anterior rexus, you can do this. Yeah. And I've spent quite a while trying to make it happen with femto, and there are many glitches you probably don't have time or interest to discuss, so far. And I even did a lab for Menosis when they had the Zepto before it went to centricity, and we could do it in the lab, posterior rexus, but they're not interested in pursuing that either. So I can't get anybody, to me, that would be if you could do a great posterior capsulotomy with the femto, that'd be one of the main reasons to have a femto, right?
Right. Well, one of the challenges, though, is for all of us in practice is like, you say it's a 150 case learning curve. And you think,
well, that's what he decided. He only had one complication in his first 150 cases, as did I. And mine was a very unusual case, but it's true. But every time you adopt anything, there's a learning curve. I mean, if you get a new phaco tip, there's a learning curve. I mean, to me, it looks like, I learned with intracap in the first years of my residency, and then extracap, huge learning curve, right? And then phaco, gigantic learning curve, right? And now we're talking about just this teeny little, you're just pressing. It's a little. I should mention, when you anterior capture, you just press on the optic, you're 90 degrees away from the optic captive junction, and it pops in. Well, doesn't really pop. You have to like be a little more gentle in walking it from optic haptic junction to optic haptic junction on both sides, because it's a 4 micron, thing. But the thing is, you have a complication, you break it, so you anterior capture it.
Yeah, you got the anterior.
Okay, so reverse capture it. You're already in the bag with this thing, and you're trying to you're doing a rhexis and you miss. So control everything and just anterior capture if you don't trust your bag, or convert that to a tiny little rhexis, or once you're putting your lens. One time I was capturing my lens, and I was trying a Hoya lens that had a more 90 degree, but it was very stiff, and I broke my posterior capsular rhexis with it. So I just picked it up and I anterior captured it. No harm, no foul.
And you're good to go.
Reverse captured it.
Yeah, so one of the issues, though, is that, now so many, I'd say the vast majority of our IOLs are single-piece acrylic lenses. All of even our monofocal lenses, #1 selling in the U.S. is for sure single-piece acrylic by every manufacturer. Toric IOLs, only single-piece acrylic. EDOF IOLs, only single-piece acrylic. And then trifocal.
Believe me, I'm aware, because I want to know what I should put in my eye when the time comes, okay? So,
what's the answer? I don't know. What's the answer?
If we have something that fills the bag, Liliana Warner has shown us that probably it's not going to cause a YAG, right? But we don't have anything that really does that yet safely by any means. Now, to me, I've been trying to talk to manufacturers about the fact that if they would put all this great technology on a 3-piece lens, nobody would, everybody would use their 1-piece, because now you'd have a backup for all your complications. You'd be able to do all of these different things, put it anywhere you like. You'd only have the inventory from one manufacturer, not have to have this special lens and that special lens. You wouldn't need to do AKs as a backup, when you can't do your toric. You'd never end up having to you have to put it in the right place at the right time, but you would never have to go back and rotate. And I think manufacturers would really be well advised, to give us something. Now the problem is there is no sulcus approved, no FDA approved sulcus lens. Correct. And no FDA approved pediatric lens, which, by the way, they're very keen to be able to do, because it's very clear we need to put lenses into children, maybe not under 6 months, but certainly over. And so there's a lot of room here for this. Of course, Marie-José, when she does her bag in the lens, can't get anybody to learn this and do it. And that's an even more challenging, because her bag in the lens requires a perfectly sized and centered anterior and posterior capsule, which this does not. This is your standard capture, and it's totally zonule dependent. So although there's no fibrosis, there is a Summerings ring, and there is added weight, and not infrequently she has these bean-shaped CTRs that she puts in to shelve into the sulcus to support it. So to my way of thinking, a 3-piece lens is already like that, and not only that, if you opt to capture, you don't need a square edge. Right. So we're going to get rid of a lot of our dysphotopsia.
Right. No, all makes a lot of sense. For those who don't know, the bag in the lens concept is you got to have a perfect anterior capsular rhexis, posterior capsular rhexis. The IOL is a special IOL that at the edge of the optic has like some lips. And that's
it's basically a flange. It's a groove into which you put both the anterior and the posterior capsule 360 degrees. So now you have your lens in the middle, and it's all zonule dependent. And interestingly, over years, you dilate that patient as far as you can dilate it. It's absolutely clear. Pupil edge to pupil edge. But on some postmorts that were sent to Liliana Warner at Utah, they found there is a Summerings ring in there, which is interesting, because that might prevent dead bag. I mean, if you allow cells to do their thing, I don't know, but that's all supposition, of course. But so I'm glad you went back and explained that, because that's something that has a lot of advantages. There are some really good articles in the literature too about having to do vitrectomies with those in place, and they do so much better than if they don't subluxate, and it's very, very nice. They can and there's so much research to be. We don't have an OCT other than intraoperative that actually images the retrolenticular space.
Right.
By the way, there's a man named Dan Goldberg who has really the most advanced theory of accommodation and has also fought the pressures of the powers that be to have any real attention for it. And he's starting to get a little recognition. And there's so much to learn about the posterior zonules and their attachments to the ciliary muscle and about the anterior hyaloid. We talk all the time about what a posterior vitreous detachment does, but we never talk about what an anterior hyaloid detachment, anterior vitreous detachment does. And there's little we know about that with regard to glaucoma and so on that really will behoove us to learn in the coming years. And no one images that. All the machines can only image to the posterior capsule or maybe a hair below or the retina.
Right. Yeah, you also brought another important topic of the idea of filling the bag completely. So I have a little experience in the area. In 2015, gosh, 9 years ago, I did the first human implantations for the lens gen Juvene, an accommodating lens, which actually comes in two parts through a regular phaco incision. But yeah, you're right, fills the bag completely. And one of the surprising things was 0 PCO rate, even 9 years later.
That's right. That's right. We do know that if we can keep that bag apart. Now, what we don't understand is about dead bag. What the heck is that? But anyhow, if you can keep that bag apart, somehow you take care of the fact that cells will continue to grow until they meet. You ruin the attachment of cells to each other, and they're going to grow to try to attach, right? And they're going to go through metaplasia and so on because they don't have their normal healthy situation with aqueous flowing and so on. So that's the shining hope. But am I going to wait 20 years for my cataract surgery? I don't think it's likely that's going to happen. So
what do you choose then?
Well, I want to talk to the LAL people. I have a little astigmatism. I would have to go with a mini mono. I understand there's a little more give. It's almost EDOF-ish. I wish they would figure out how to put a little more technology on their LAL. And if the perfect lens comes, where you can redo, all these refractive index shapings, that'll be fabulous. But the LAL at least is a 3-piece lens. And I don't know if anyone has experience in sulcus implanting that and optic capturing it. And I was going to talk to those folks about it. Do you know?
Well, so we've had a couple of videos for CataractCoach, and one of the warnings is that the haptic optic junction, like for a Yamane procedure, or even optic capture through the rexus, apparently is not super strong, and they've been known to disinsert.
And, I don't know about, treating them in inverter space. I don't know how that would go. I guess there's no research about that, but it looks like this instead of like ideally, here's my optic, here's my haptic, and it's like this kind of, not like that. So it's not, so I didn't know, I never have read or talked to anybody who's tried to sulcus implant those, but if they would just, fix that. And then, there's been a big to do about the Lucia lens for Yamane, the haptics. Steve Safran first recognized this, and they can twist in there. And if the eye goes hypotenuse at all, even though that PVDF, haptic is the strongest and the best, if it doesn't stay put in the optic, you're in a lot of trouble. And they don't know why that started, and I don't think that ever got a handle on that. So that's a little bit of a crapshoot itself.
Yeah, we feature those videos on CataractCoach, where basically the haptic-optic junction of that CT Lucia lens is very loose, and you can get it. Literally, the haptic can be spinning in there. So we've had some innovative surgeons who now use like the retina endo laser to really kind of melt that area a little bit more to help ensure a better fit. So
I didn't know about that. That's interesting.
I'll send you a video link. It's already been shown on CataractCoach.
Oh, I'm sorry, I missed that somehow.
Well, with 2,000 plus videos, it's hard to see them all. But I think you're okay with a silicone material for acrylic for your eye?
Well, we know silicone is more biocompatible than acrylic, whereas acrylic is more capsule compatible. So if we're not worried about the capsule compatibility because we're going to optic capture, then that's not really an issue. And it is more biocompatible. Now, I have heard that, in multiple locking ins or whatever, with the LAL, that these may become kind of fragile altogether. I don't know if you would be more on top of that than I am. But silicone per se, I don't have a problem. And you know what? We used to have the Star AR our 40 series, where we had elastomide haptics that were actually wide enough to actually fit most sulcuses, whereas, our current three-piece lenses don't fit the sulcus. Remember that?
The AQ
The
2010.
AQ,
Yeah.
2010, I think it was. I don't know.
Yeah, you're right.
Anyway, the AQ series were silicone. They were great in the sulcus,
Right.
and it was the only lens that you could really reliably put in the sulcus and not have to optic capture. And they were quite safe. They didn't have a square edge, so they didn't create UGG, and they had long enough, good memory. PMMA does not have decent memory at all.
Right.
So those haptics, when we put them in, they're just toast from the point of view of the memory of their shape, within a couple of 3 weeks. If you look at the actually degradation charts of the memory of the shape of these PMMA haptics, they don't really stay that strong. And I would never put a 3-piece lens in the sulcus without either optic capture or some sort of suture or something to hold it steady, because there's little micro movements, and they'll almost always find their way to whatever little zonial problem or capsule problem you had in sunset or sunrise, later in life.
Right. That star lens had a bigger 6.3 millimeter optic, and then the overall length of the lens, haptic to haptic, was significantly larger than what
that was the key. That was the key. And it had good memory. They were elastomide, which had good memory.
But we don't have that.
Quit making it.
So that's one of those things where I guess ophthalmologists need to be a little bit more in the ear of the manufacturer. Say, listen, we need this. Don't stop making this thing.
Oh, I've been yelling, but nobody listens to me because I don't buy anything anymore. It really helps when you do high volume. It really helps that you get a much better relationship with industry. But I never took any real consultants fee. I had a couple of unrestricted research grants, but I never ever in my lifetime actually had a significant consultants fee. And on the one hand, maybe that was stupid. On the other hand, and bad negotiation, whatever. But on the other hand, it left me free to choose whatever I thought was best for my patient at the time, and to explain to people why.
Yeah, interestingly, so I did both sides of that coin. So I was a consultant for a lot of the companies with a long disclosure list, but in the last 10 years, essentially nothing. So I will work with small startups where I do love the idea, want to work with them, develop this. Maybe I'll have some ownership stake in it, but I don't do any consulting for the big companies, because I, like you, want to have that freedom to just let me talk from the heart and from the mind.
I mean, when the Sovereign first came out with the very first non-continuous phaco, I immediately switched to that, and I had to explain to people, why and how great it was and all that, and I really pissed the competitor off, let me tell you, who I was using, and then they came up with something a little better, and I switched to them, and so it's like although individuals love me, actually corporate never particularly loved me. But patients did. That's all that really mattered to me, is my outcomes and my patients.
Of course, your loyalty to your patients first, and your practice and yourself, and then loyalty to any company, that's not important. I'm totally with you, 100%.
And we need them. We need them terribly, and they're wonderful. They're wonderful, but the bottom line drives them more than it drives us.
Yeah, but for sure, be loyal to your patients. Now, you're keeping up with, gosh, I saw you at a meeting in Tampa, Florida, and you're keeping up with all. So even though you're not in clinical practice anymore, you're still very much interested in teaching and sharing your knowledge.
I get a lot of positive feedback from it. Every time I give a lecture, it seems I'm invited to give another. And the key thing is, my biggest fear is I need to know when I'm no longer, for example, I found out from you, my videos are no longer of the quality that they really need to be. And I had some very important teaching points in those videos, so I don't want to be, I don't want to outstay my welcome, so to speak. I don't want to be, say, and of course my cases are old. The amazing thing is that a case that I did so long ago is still very valid for teaching and so on, if not the right quality of teaching, of video. I'm intellectually stimulated, and I have a great deal of joy in this knowledge. And my husband puts up with me, the fact that, I don't get paid for anything and I pay to teach. And, it's just one of those things that, sometimes I even miss a birthday party now, of a grandkid, because of a meeting, darn it, or a performance of my opera singer daughter, or my funk soul a cappella songwriter song daughter, or my cantor daughter. I have a lot of art in my family, and no doctors, so I'm not sure who's taking care of me.
No, I'm sure you're great. Well, I love your passion. I love your passion for all this, your passion for teaching. Yeah, in terms of videos, the new generation, the younger ophthalmologists, say in their 30s and 40s, will not watch a video that's in the old definition of basically 640 by 40 pixels.
Yeah.
I featured those videos before on CataractCoach.com, and they get 1/10 the views.
I understand, but the points are still valid. So,
no, for sure.
Yeah. So what I have to do is I have to teach somebody with a great video system how to do it. And actually, Burkhard Dick offered to do that, but I think he's been so busy that he hasn't. When that actually happened, Burkhard said to me, "Why don't you just tell me what to video, and I'll video it. I won't even say it's me. We can say it's you." And I said, "No way that's going to happen, But I would love that if somebody would do it my way and let me explain why it's valid." The other passion that I have is for brunescent cataracts. I had every cornea look the same as the 2050 cataract the next morning, though it was a 20-minute case, to do my circumferential disassembly with cross-action vertical chop, which is something I described in 2006, but couldn't get anybody to learn. It involves using burst mode, and it's another passion of mine that people do not have to lose endothelial cells because they have a brunescent lens, and I really never had to convert. And of course, you want to learn M6 because that's how you want to convert rather than extracap these days in case you need to, or even make a partial incision without entry before a brunescent lens. But if you learn my technique, you will not need to convert even. And believe me, in Iowa, they came off the farm with true brunescence that Indians would recognize as that. That was another passion of mine. The Sathis in Delhi came up to me one day after a lecture in 1994 and said, "Would you come help us create an indigent eye hospital?" And my husband and I have been 5 times there, and we worked with them not only on surgery, but we brought our lead tech and our lead scrub nurse who didn't even have a passport, had never left Iowa, and took them right to Delhi, and then they later got wonderful money from Mormons and have built an amazing unit. I've tried to get them the Chang Crandall Award, but it hasn't happened over these years because they've really done thousands of free surgeries and seen millions of people in free glasses and everything. It's another passion. I was never able to operate with a knife and a fork. I was always a control freak, so I only taught the surgery. I didn't go to camps and do large volumes. I just can't do that.
So if we want to still learn from you, obviously we'll see you on the podium, but are you still doing the hands-on in the wet labs at the ASCRS and the Academy? Because that's my fondest memory.
Well, I started actually the anterior vitrectomy wet lab in 2006 at ASCRS and also at AAO, but the retina committee at AAO made me give it up within a year because I was teaching pars plana, one port pars plana, and they didn't think that was appropriate at the time. And I continued with the wet lab at ASCRS until 2 years ago when somebody came up to me and said, could we have some new blood? You've been doing this so long. So I have just bowed out of that. So no, I no longer do the wet labs, and I don't feel that I should be an instructor in a wet lab, although I did lots of iris and lots of anterior segment reconstruction. I just haven't had my hands in it for so long that I've accepted myself from that area. But I do once in a while when someone wants come and observe and make notes and compare videos and talk about potential things that could be improved and that sort of thing.
Fantastic. Well, we'll continue to learn from you on the podium and obviously from the large library of amazing teaching materials you have out there. I just want to thank you. What an incredible podcast. You've done so much for our field. You have directly influenced thousands of ophthalmologists who've then treated basically millions of patients. So truly outstanding.
Thank you so much. And I have the utmost respect for you and what you've done. And it's an absolute privilege to be part of this podcast today. Thank you for asking me.
My pleasure. And I want to remind our viewers and listeners, remember, we got a new podcast every single week. It's on Apple, Amazon, Spotify, Google, YouTube, anywhere you find your podcast, you find the CataractCoach.com podcast. Also, remember, check out our website. We got that free PDF book, How to Learn Cataract Surgery, the free 25-part curriculum series, and of course, our free daily email. And we're still doing a new video every single day. We will catch you next time.